So I am now pleased to introduce you your webinar chair, who is Dr. Rajeev Raghavan. So over to you.
Thank you very much. Welcome to everyone who's joined us today, and I hope some more might be joining shortly. I think we have had a long list of attendees who have signed up to this webinar. And I can see why, because this is a really important topic at this point in time, and more so since we've tackled with a worldwide pandemic since the beginning of 2020. Whilst we may know what this is about, I'm sure we're here because we want to learn more about how we can recognize and deal with this important area within ourselves and our colleagues. And we have a very eminent speaker in Dr. Dorothy Frizelle, who's a consultant clinical health psychologist and head of psychology at Mid Yorkshire and Hospitals NHS Trust. Dorothy has a wide-ranging experience in this area and has a particular interest in diabetes and diabetes-related burnout and psychology, and in fact is party to the UK NICE Diabetes Guidelines Update Committee, which looks into all aspects of diabetes care. So without further ado, I shall welcome Dorothy. Please make sure that you feel free to ask any questions in the question and answer box during the meeting, so that we can try and sort of collect any themes and present this to Dorothy as we go along. If what we try and do is get a balance between trying to cover everything that Dorothy would like to cover today, Dr. Frizelle, and I'll also make sure that we ask the right questions at the right time. So over to you, Dr. Frizelle.
Hi, hello everyone, and thank you for the lovely introduction, Rajeev. I never recognise myself in these introductions, but thank you very much. Also, a big thank you to Abbott Diabetes Care and SBK Events for the opportunity to speak with people today. I'm actually working from home today doing this from a very, very rainy Lancashire. So I'm hoping there's no thunder or lightning is going to interrupt play technically in any way, shape or form, because it's pretty grim here at the moment. I don't know if anyone else is in this part of the country. So I'm just going to share my screen and we will get started. And there we are. Hopefully people can see that and that we are on full screen.
Yes, we can. Thank you.
Brilliant. Thank you. Okay, so I'm going to be talking today about overcoming burnout in your diabetes team, but also thinking about burnout, stress, distress in relation to ourselves a little bit too. And as Rajeev said, I'm always much happier with interactive sessions, and I know kind of remote webinars don't always allow for that. So what we've tried to do is build in some sort of questions embedded into the presentation, rather than lots and lots of me talking at you and then trying to pick up questions afterwards. So hopefully that will work. So before we start, I just need to post my disclosures. And let's have a think about what we're going to be talking about today. Why is this an important area to consider? And the bottom line really is because if we as healthcare professionals are happy, well, and engaged in our job role, then that translates into much better quality of care for the people with diabetes and the families that we serve. And ultimately, that's going to have a positive, beneficial impact on diabetes outcomes. So this is one of the nice and important things to look at from a well-being point of view, but it's also important to look at from a diabetes outcome point of view. And I would argue that really strongly, because we know that strong positive correlation between good staff well-being and good patient and staff experience and outcomes and KPIs. So what is burnout? Well, I can definitely tell you what it's not. It is not a medical anxiety or stress-related disorder. And I think this has caused a lot of difficulties over the years, where people would think of burnout as something that was wrong with them, that they couldn't cope, or they weren't resilient enough or tough enough, or a good enough clinician or nurse in order to be able to cope with the realities and the demands of working in healthcare. This is a really, really naive and outdated way of thinking of burnout. We know that burnout is not a medical anxiety or stress-related disorder. And the WHO have actually updated their International Classification of Diseases manual to reflect the fact that actually burnout is a syndrome conceptualized as resulting from chronic workplace stress that's not been successfully managed. So it's really important that we start to conceptualize burnout as a workplace challenge. It's actually one of these things that is a risk in the workplace, equivalent to if we were working in a chemicals factory, there is risk of burns from chemicals. So we would need to take appropriate precautions, we would need to have appropriate education to mitigate against that risk. In the same way, burnout in healthcare needs to be conceptualized in that way. And I think that's important as well, because hopefully in thinking of burnout in this way, it will take away some of that stigma associated with it, that it's embedded in the person, a sense of lack or inability in the person themselves. And actually the problem is in the workplace and the systems in which we're existing and working and managing. So the WHO characterises burnout across 3 main dimensions, listed there: feelings of energy depletion or exhaustion, increased mental distance from one's job and or feelings of negativity or cynicism, and reduced professional efficacy. I'm going to say a little bit more about these in a second, but we don't want to go too much into diagnosis of burnout, because hopefully this session is more about understanding it and recognising it earlier in order to undertake some good preventative actions for ourselves and teams. And importantly, it's not an all or nothing experience. That idea that it's not a medical diagnosis, we don't have it or don't have it. It exists on the continuum, and we can be at different points on that continuum at any number of different points of a working day, let alone our working life. And actually, healthcare professionals are much more likely to experience chronic stress and distress over the course of their working week or working life than to experience full-blown burnout, which is fortunate, although burnout still is a prevalent and important problem, which is why we're talking about it. And I think it's important, again, to think about the fact that burnout exists on this continuum, because we don't want to pathologize feeling stressed at work, or having had a tough day at work. That very often, sometimes those tough days or those stressful days are days that we find to be very meaningful and significant and give us a good sense of purpose. And we don't want to be pathologizing that and labeling that as burnout unnecessarily. So why is it important to know and understand about it? Well, we know that NHS work is demanding, healthcare work is demanding, and there's a summary of some of the facts and figures that a high proportion of NHS staff at any one point in time will experience stress, distress, and a proportion will experience that element of full-blown burnout. And this is related and correlated with vacancies, staff leaving, staff turnover, staff not being able to be replaced, which then exacerbates the problem because the existing staff in post are working on depleted numbers and having to pick up the slack, which makes it more difficult. So we can see how, as a problem, this is a very significant one from an NHS systems organisational point of view, let alone the cost, as well as the human cost. We also know that the evidence is strong for any interventions that help to reduce workplace stress and demand and difficulty, and to mitigate against the effects of distress and burnout. We know that interventions like that are effective. Most work, there's a good evidence base for them. And we also know that supportive organisations that reduce reliance on promoting individual resilience and instead work on creating good positive conditions for people to work in actually do better on all the key staff and patient performance indicators. And the evidence is so strong for these correlations and links that actually NHS England now has an entire unit dedicated to looking at staff health and wellbeing, which people, I would hope, are familiar with. If not, on the NHS website, have a look, type in NHS People Plan, and you'll come up with all sorts of pages of different information, evidence, tools and information. Not least of which part of that work undergoing at NHS England level relates to the People Plan, where one example of an intervention that's now a requirement for everybody working in the NHS is to have an individual health and wellbeing conversation. And this is a focused conversation that is dedicated purely to looking at your health and well-being, the things that help you flourish and do well at work, and the things that you find challenging at work. The aim being that those things can be addressed and improved for you and your colleagues. And of course, we can't be talking about burnout at this point in our history without thinking about the fact that we've just come through, or are almost through, a major global pandemic. You know, while the COVID-19 crisis has been a physical health crisis, it's now really well recognised that it's also a mental health crisis. And the WHO and the United Nations are both recognising this. And in terms of looking at global international evidence, have shown that at-risk groups, of which there are several, but particularly frontline healthcare workers, are in those high-risk groups. So it's actually an important competency, I think, to start looking at this for ourselves and our colleagues and the teams that we might support and manage. So how specifically has the work of the Diabetes MDT been impacted in recent weeks and months? At the start of the pandemic, people were probably aware that people with diabetes were initially described as clinically vulnerable, but very quickly that was changed as emerging data showed that actually people with diabetes were at much higher risk of dying in hospital with COVID if they also had diabetes. And the odds of dying in hospital from this data I've cited here is almost 3 times as high if somebody had type 1 diabetes and COVID, and almost twice as high with type 2 diabetes and COVID. We also know that there have been increased numbers of people being diagnosed in severe DKA for all sorts of reasons, hospital avoidance being one of those reasons cited. And we know that people who are diagnosed under those circumstances can then go on and have more challenging experiences of diabetes care. So we know that people with diabetes have been an at-risk group, and you're probably all seeing that way more than I can describe or state in a presentation already in your clinical practice. We also have to think a little bit more widely as well, beyond the physiological risks conferred by working with people with having diabetes and in our work with people with diabetes. And that relates to the fact that we know that the pandemic has disproportionately affected people from vulnerable groups. So if we have people with diabetes also in these vulnerable groups, then their psychosocial needs are arguably going to be much higher. We know that people with diabetes have coped with additional distress of lockdown and social isolation and all of those other challenges we're all now very familiar with by undertaking behaviours that, while arguably helpful for them in terms of their coping, are not helpful from a health or diabetes perspective. So using food as a way of coping, alcohol for some people, drugs, smoking, reducing activity, those sorts of things. So we know that ultimately there are 2 key areas of diabetes psychology concern as a result of the pandemic. That is the extra demand being placed on you as healthcare professionals in supporting people with diabetes who have also experienced that pandemic, as well as having to support people with diabetes in their additional stressors and difficulties as a result of the pandemic. So at this point, I just wanted to stop and hand over to Rajeev to see if there might be any questions or comments.
Hello, can people see me? Yeah. So that's really interesting overview there of what the problem is and how, one can view it slightly differently. I mean, maybe we should have RIDDOR reporting of stress and workplace burnout, same as we do for chemicals. How does all this play out in your own areas of work? It would be really good to sort of have some thoughts and experiences that you might be able to share, any questions you have from what you've listened to so far. Do you feel that this resonates with your own sort of experience, what you've seen or experienced yourself or seen colleagues go through? It'd be really important to sort of see if we can share experience from you guys, as well as telling you about what we think is happening. So feel free to post your questions. We'll carry on for the moment because at the moment there are no questions come up yet.
Yeah.
In the interest of time, so that if we have questions and discussion at the end, we should hold some time for that. Thank you.
No worries. Okay. So how can we start to spot this thing called burnout, distress, stress, all these different labels? What does it mean? How can we start to spot it? How is it different to feeling stressed in general? And this is what we're going to talk about in the next few slides. So we know that global prevalence rates of burnout are quite high for people working in healthcare settings. They run at about 11–12% for nurses, but worryingly, almost 50% for both doctors in training and practicing doctors, medics. And interestingly, for both nurses and medics, which are the two professional groups that the majority of research has been undertaken on, length and duration of experience isn't necessarily protective against experiencing burnout. Arguably, in some studies, it's been shown to increase risk. So it's one of these things that we need to be aware of at all points in our career, no matter how experienced we might be or how long in the tooth we might be. With regards to burnout rates, specifically for diabetes staff, very limited research. I would argue probably because of the enduring lack of psychology within diabetes teams, and psychologists would normally undertake this sort of research. There is one small study from India that looked at doctors working in diabetes reporting higher levels of burnout versus other fields of medicine, but that's certainly something to be thought about and researched more in future. So what are the factors that can specifically in relation to us as healthcare professionals working in diabetes teams that can increase our vulnerabilities? And there are a few key ones, I think. The main one being the fact that for many of us working in diabetes teams, we can form really close and long-term relationships with people with diabetes and their families. And while this is one of the really rewarding aspects of working in diabetes, it may also come at a cost because we form those attachments, we can really care about people, we can get to know them, we see them at all different points in their lives, the high points and the low points. And we have, if things happen to people with diabetes in their lives, it's not separate to their diabetes. You know, the diabetes doesn't tick along beautifully while they're dealing with bereavement or death or loss or worsening illnesses, comorbidity. That, you know, things that happen in people's lives impact their diabetes and vice versa. So that close and long-term relationship is something that can put us more at risk of being vulnerable to the risk of burnout in working with patients and families. I think the treatment paradigm for diabetes being supported self-management is also maybe something that can increase our vulnerability to risk of burnout as diabetes healthcare professionals, because when we're talking about getting people to self-manage and have it being supported in their self-management, what we're trying to do is get people to have higher levels of self-efficacy, and we're often trying to get people to change their health behaviours, to either do more of something or do less of something, or arguably both at the same time across the range of health behaviour changes. And most medical and nursing staff training really doesn't cover those aspects of medicine, psychological medicine, in any great detail. And we know there's extremely limited funding for qualified staff to access that kind of training, so people can feel that they're on top of their skills and upskilled, so they're not left in a position where they're feeling out of their depth or unsupported or unsupervised. So there's something about this self-management treatment paradigm in diabetes being the main paradigm and main focus can also tip healthcare professionals, doctors and nurses and other therapists working with people with diabetes into this sense of, you know, I'm struggling here. We're doing everything we can, but we're still not achieving the HbA1c or the blood glucose that we need to. And that can lead to feelings of undermining confidence as well. So what other factors can increase vulnerability? Well, there's something that's also really important about the increasing role of technology in diabetes management. I mean, I'm not a technical person, and I feel very often it leaves me behind that, you know, we've got insulin pumps, flash glucose monitors, continuous glucose monitors are being all widely used. And now, you know, this this increasing role of technology in diabetes has necessitated a really radical shift into understanding numbers and data that now healthcare professionals in clinics need to be as familiar with understanding computer algorithms and graphs and data as they are in terms of talking to people about injection technique or adherence to medication regimes or similar. Also, I think as well as new devices and new approaches are promoted, and the widespread use of social media and advertising and marketing by companies, which is not a criticism at all, arguably a good thing. I think as a population, people with diabetes are much more aware of what might be available to them, which means that they may be coming to their diabetes teams requesting and asking for different access to different technologies and different interventions. And that can put people in diabetes teams in that difficult role of gatekeeper as to whether or not someone should or shouldn't or can or can't have something, which can also place demands on people. And then there's something about staffing and role clarity, that we know that staffing for diabetes across the range of healthcare professional groups has not increased in line with the massive exponential increase in numbers of people with diabetes. That I'm just checking my figures here. We know that only 52% of services meet the Royal College of Nursing recommended nurse to patient ratios at the moment. And as well as staff shortages, there are multiple challenges for those in existing roles. As far as I'm aware to date, there's no structured pay banding for diabetes specialist nurses, no clear structured career path for people to take. So progression can be unclear, and there can be really significant variation in role expectations. And then last but not least, the impact of the global pandemic, which we've already talked about. I think it's important as well to have a think about this idea of barriers to help seeking. And I'm not going into this in any depth. I mean, it's a whole session in and of itself and then some. But we know that healthcare professionals are notoriously bad at seeking help if they're feeling unwell physically or psychologically themselves. Lots and lots of reasons for this, as this slide hopefully highlights, but maybe some of the things to think about after today's session for you are that if you have noticed yourself feeling distressed, stressed, degree of burnout, what are your particular reasons for ignoring any signs or symptoms? What do you say to yourself to justify not seeking help? Does it make you feel weak? Are you okay with seeking help, but you exist in an environment where culturally that's just not permitted or not the norm or not acceptable? Definitely worth thinking about what the barriers might be for you as an individual in and of yourself, but also in the work environment that you exist in, that might prevent you from reaching out and asking for help. A little bit of a nod to this idea of compassion. Compassion being this this notion of how care is given through relationships based on empathy and respect, this idea of intelligent kindness, clinical empathy being, as I would describe it, psychology describe it, a higher level metacognitive skill. That is the ability to think about how other people are thinking and feeling, and to marry that with our knowledge and understanding of what might be good and ideal for them from a diabetes perspective, but undertaking that in a way that is consistent with their values and what's important to them. So arguably, we all want to have really good high levels of clinical empathy, high levels of intelligent kindness and clinical compassion. But do we always apply that to ourselves? In my experience, healthcare professionals are notoriously bad at being self-compassionate. They can be dreadful to themselves. Arguably, maybe I see a biased group, biased cohort, but for people who, for your vocation is about helping people and supporting other people, do we show that same intelligent kindness to ourselves? And I just want to throw in this reference to this interesting article written by colleagues near me here up in Liverpool, talking about this idea that we have a keen sense of duty to care for the mental and physical health of the people that we look after and their families. But it's really important that we also need to remember that we also have a duty of care to ourselves and the people we might be supervising, training, or managing as well. So maybe some questions to ask yourself, and this is by no means an exhaustive list. One of the really significant ones, I think, is this idea of, have we become tolerant to distress at work? This is something that we try to talk about in my team an awful lot in my workplace, this idea that being manically busy and overworked has become normal. And actually, if you're not manically busy and overworked and struggling, then that's the outlier. What's the impact of that on self and others? Should that be allowed? Has that become a cultural norm? And we need to start to challenge that. Do we see distress as a necessary part of our job roles? And if we do, and arguably we do in healthcare, how much is too much? At what point would we know that? Who would we talk to if we were at that point and recognizing that? What would stop us from reaching out? So, thank you, Rajeev, you're ahead of me. Yeah, moving on to any questions or thoughts in relation to spotting it, recognizing it in ourselves.
No, I mean, amazing. Again, I think this is making us all think, and certainly making me think about various aspects of my own practice. And it's a time for reflection, and also see how we're approaching our colleagues who turn to us for help or support. What's the culture we're creating? That's also in the chat box. A lot of people have mentioned about culture, about support when someone approaches you with a problem, or if you approach your manager with a problem, and so on. Yeah. A few questions coming up, if I may pose them. One is to kind of say, one is more broadly about the fact that mental health, psychological health doesn't seem to be part of a holistic review of the person with diabetes, although it's there in the guidelines, it's there in NICE, it's now in the latest ADA EASD consensus statement. Why do we think that might be that we're struggling to still put that into practice on a regular basis? And particularly when we know that, if we don't have mental health sorted, we might not achieve the outcomes we need for our patients. And in turn, dealing with mental health repeatedly whilst not getting the outcomes, as you say, causes or could be one of the factors for burnout within healthcare staff as well.
Absolutely, yeah. I think that's such a key question. I wish I had a coherent answer. I think there are various reasons as to why we don't include, mental health, psychological well-being as part of routine care. I mean, I would argue and have argued that psychological well-being and checking for levels of diabetes, distress, and or anxiety or depression should be part of the diabetes care processes, as important as checking someone's eyes or feet or blood pressure or weight.
Is there anything from your own sort of area of practice where you feel something could be easily implemented in a clinic setting? Because one of the challenges, I suppose, is people not being aware of how can I do this quickly in a clinic when there's time pressures. Yeah. And I suppose to me, the other aspect of this, I suppose, is if we start asking questions, what are we going to do with the answers?
Yeah, absolutely. I think part of the problem is related to the fact that we still don't have embedded psychology across diabetes teams in the same way that we would have dietitians or podiatrists or nurses, even medics. So that there's a little bit of a self-perpetuating problem that those folk aren't in the teams, therefore it's not something that's picked up and embedded as part of the team. So if you're fortunate enough to have a psychologist, I would say definitely nudge them and get them to support you in implementing some kind of screening or checking out, or some teaching or training to support skill development around asking those questions to check that out. But if not, I think there still is a lot that can be done. I'm going to go on in a little bit and talk about a couple of screening measures that can be used, but there's a whole host of other information in relation to people with diabetes in terms of distress. Screening is okay. There is that issue of what do we then do if we unearth some difficulties. My argument with that is, if a person with diabetes comes in and talks to you about the fact that they are having horrendous rectal bleeding, as a doctor or a nurse or a dietitian, you wouldn't say to them, oh, that doesn't sound very good, but don't tell me about that because that's not my area. Let's just focus on your diabetes. Let's not open that can of worms. You would acknowledge and say, that sounds really awful and really difficult, and I need to signpost you on to the relevant person. I can't deal with that. I don't know what's going on. I'm a diabetologist. I don't deal with rectal bleeding, but let's get something done about it. My argument would be that the same should happen for people expressing distress and difficulties or low mood or risk of self-harm in whatever way, shape or form.
Absolutely. Yeah.
That we actually have a moral duty to ask about it. That doesn't mean to say there is an expectation that we fix it or even do anything about it, but we are all capable of signposting on and linking up.
That's a very good analogy you gave. I mean, I'm really pleased with the analogies you're giving, because it immediately creates images in my head. And essentially, it's the permission to ask and find something which you can't fix. It's not a problem. You still should find out if there's a problem, even if you can't fix it. That's so important.
Absolutely. Yeah.
I think another question is about the pace at which technology is changing, and whether that's one of the reasons for burnout that healthcare staff are feeling, particularly in diabetes. Pace of change, I think that's generally the issue with the pandemic as well, isn't it? Everything's changing. There's crisis after crisis.
Yes.
And it's just jumping from one to the other.
Yeah, absolutely. That sense of people not being able to get to a point of good self-efficacy as healthcare professionals, where they feel, you know, I understand this, I know this, I feel confident in my skills and my abilities, I know what I'm doing, and then able to get that sense of reward and meaning and purpose from work. If the context and the background is constantly changing and there's constant requirements for learning and we're always feeling behind the curve, that in and of itself can be stressful. Yes. Yeah.
So I suppose people would want to know about the screening tools that we can use and so on. So we'll move on in the interest of time. But I'd be, one of the attendees has asked if there's any case studies that you can share as an example of how this comes about and how it's dealt with, and if you can.
Yes, I'm happy to do it. I'm happy to give some information related to screening measures for diabetes. I don't have that on the slides, but I'm happy to share that through folk afterwards with the slides. That's not a problem.
That'd be fantastic.
Okay.
Thank you.
Okay. Are we moving on, Rajeev? Or is there anything else?
Yeah, I think looking at the themes, I think there's issues about sort of whether support is there for people if they raise concerns about themselves or other people. Some people have shared their own bad experiences in terms of raising an issue, but then feeling fobbed off or having sticking plaster, as it were, and then having to find support themselves. So perhaps again, if there are any hints and tips that you can share in the rest of the presentation, that'd be helpful.
Yeah, hopefully, yes. Unfortunately, I think very often that can be the case, that even when people do seek that help or reach out, they might not always receive it. I would like to think that certainly in the NHS that is changing with things like the people plan and this whole focus on staff well-being. I think it would be a very I don't want to use the word courageous chief exec that would hammer the line now of saying, well, just get on with things, be more resilient, just get on with what needs doing. That would be a bit of career suicide. So because of the pandemic, one of the positives arguably from the pandemic is that I think that the attitudes have shifted to recognizing that actually demands are high and huge, and this whole thing about it's okay to not be okay, and that to be more acceptable. I think the sticking point, as you described, Rajeev, from people's comments and questions, comes in when people reach out and there's not services embedded and available. I'd say that I guess two things. There is always access to support through own GPs, if not in the workplace. Improving access to psychological therapies, IAPT services can be very good. People can self-refer in many places to those. So seeking help through that more traditional mental health route can be useful and helpful. But also I know that NHS England has set up a whole range of hubs across England. I'm not so sure about what might be available in other 3 nations if this session is going out UK-wide, where these are regional hubs with a focus on supporting staff wellbeing, offering a whole host of interactive online, one-to-one, face-to-face modalities, interventions, if you like. Some variation across different hubs, but a lot of things available, and also a lot of preventative interventions too. So things like critical incident stress debrief training, so people can understand in advance the sorts of things that they can do that might help in the event of distressing incidents and events at work. So I'm hoping that helps somewhat.
Absolutely, and I'm sure there's some more things that you're going to share in the rest of the presentation that's relevant to this.
Sure.
I think we'll move on in the interest of time, but there's a few other themes which we can come towards the end based on what other people come back to in the chat. Thank you very much.
Okay. So thinking about this section of this presentation being on, well, what can we actually do about this? If we recognise that this is a workplace occupational hazard for us as healthcare professionals, we're not immune. We need to be showing some self-compassion as well as compassion to others to think about our own well-being, not just because that's the right thing to do morally, but also because we know that if we are working optimally in terms of our well-being, then we are doing a much better job with patients and ultimately impacting diabetes outcomes in a good way. So what can we actually do in a practical sense from the point of view of ourselves, but also from the teams or systems that we might work in to promote well-being and mitigate against risk? And I think this is a really nice analogy from colleague Anna Baverstock down in Taunton in Somerset. She uses this analogy of a phone battery that most of us have got mobile phones or devices of one sort or another, and as the battery is starting to get low, we don't leave that device to kind of run out and die and be completely not working before we plug it in. We look at it at the point it's like, we need to plug in and we need to recharge. And is there something about us looking at ourselves in that way and thinking about where we might be in terms of our battery levels, and at what point, how low do we allow ourselves to run before we start to recharge? And do we really want to allow ourselves to just completely run out of charge entirely and switch off and be non-functional? We can also think about this analogy in terms of the teams, diabetes MDT that we might work in as well. Whereabouts is the team in terms of their battery level, and what might we do to recharge? I think it's also important for us to think about the fact that work doesn't exist in a bubble, and then our home lives exist in a bubble, that those things interact and compete. So things can be okay at work and we can be managing, but there can be things going on in our home life that can then increase our risk of stress, distress, or burnout, and vice versa. Again, this is not an exhaustive list, but hopefully it gives a nod to some of the things that can increase our vulnerabilities. And again, maybe something useful in having a look at some of those and thinking, well, what might be going on for me here, and what might I want to look at or try or seek some help or support with that might make a difference for me in terms of recharging that battery. Also, a kind of this looks like a very busy and complicated slide, but really it's quite a simple summary really of kind of what happens in response to threat. That signs and symptoms of stress, distress are really quite normal. Remember earlier we said we don't want to be pathologizing feeling stressed, that there can be lots of benefits sometimes in feeling stressed. It can motivate us to do the things that we need to do. But generally, the signs and symptoms of stress, distress are our way of signaling the fact that something's going on that we find threatening, work or home or both, or generally. And this activates in our brains. As human animals, we have very highly developed emotional regulation systems, summarized there as our threat system, our drive system, and our soothing system. So when we have very high levels of demand at work, and or if we've got things going on at home, our threat system becomes activated. And this gives rise to release of adrenaline and then activation of fight or flight response to varying degrees, where a full-blown fight or flight response can be experienced as a panic attack, whereas lower levels of adrenaline can be experienced as different signs or symptoms of stress and distress. And again, it's worth taking a minute to think about how you as an individual experience stress. What is it that happens for you? What are your tells? What are your signs? What are your red flags to say, do you know what? This isn't good. This is, you know, I need to do something to calm myself down, or to step away, or give myself some time out, or take some time off. Some people have any and all sign and symptom, physiological symptom of the fight or flight response, that higher levels of cortisol and adrenaline. Some people maybe just have one or two. So it's worth having a think about how you manifest and show those physiological signs and symptoms. But there's also something important there about the behavioural and cognitive signs and symptoms we might show, that we might not be manifesting stress or distress physically, physiologically. We might be manifesting it up here cognitively in terms of what we're thinking. We might have racing brain. We might be asking ourselves lots of what if questions, all of those sorts of things. And behaviourally, it might be that actually we're not really aware of, you know, any major physical symptoms or what's going on in our heads too much, but we might notice we're maybe drinking more than we would like to. You know, having one of those extra glasses of wine during the week when we'd really rather not. We're no longer going out walking. We're not visiting with friends at the weekend, or family, or seeing people at the weekend. So stress and distress can manifest not just physiologically, but also cognitively and behaviourally, as well as emotionally. And very often, certainly what I've found in clinical practice is that when people are in this threat mode, when there are high levels of demands at work and they're in threat mode, what do we tend to do? Have a think about it from your own point of view. What most of us tend to do is we tend to move into our drive system. We tend to work even harder to try to overcome the threats and the demands at work. So we try to do even more. And that's great if the threats are short-term and time limited, and working harder can clear the desk or address the problem. But as a way of coping and managing with chronic, sustained high levels of demand, not such a helpful way of being, moving between this threat drive, because ultimately that's going to have a physiological and psychological impact. And is there something about we need to stop and think about how we can break that cycle of threat and drive and move into soothing system, soothing way of being, where we can allow ourselves to feel more safe, more contented, more calm, more relaxed, more connected as well. Big aspect of social support tied in with that soothing system. So this is just really an illustration of how we might map out stress, distress, burnout for ourselves. But it's not just about physiological signs or symptoms. Actually, it can manifest across any and all of those domains. Classical behavioural response to anxiety, distress, any threatening situation, or any situation we perceive as threatening, is avoidance, which is an interesting one. Again, think about it from an animal point of view. High levels of threat, a bit of our brain notices that, so it activates fight or flight, so we can move away or fight off the threat. Arguably, most of the time, avoidance is useful because it's less threatening and harmful potentially. But if the stressful thing is work and we're having to go into work every single day, then that's more difficult to avoid. So that's worth having a think about. And or are we still going into work and working very hard, but have we stopped having those conversations with people? Have we stopped taking that 10 minutes to have a walk around the main hospital building if the weather's nice with our colleague, and catching up on what's going on with home and family? You know, are we putting that behavioural avoidance to try to manage threat, distress into the wrong things that actually are making the situation more difficult rather than easier? Talking about assessment measures, people probably are familiar with the hospital anxiety and depression scale. That's just one measure of measuring and managing distress. It's available on the NHS website. There's a screenshot of it there. I think it's quite a useful tool for us to have a think about for ourselves and or colleagues, just to have a check over and a look-see of where we might be at, and to give us some pointers as to any signs or symptoms that might be breaking through and for us to see. Really important to emphasize that any scale like this is not diagnostic. If you score highly on it, it doesn't necessarily mean to say you're clinically depressed or mentally ill or suffering from burnout, that these are screening tools and screening tools only. This website is particularly good because it provides you access to the screening tool, but it also gives lots and lots of pointers and links and signposting to different sites for different bits of information and help and support. I think this is a useful slide to have a think about as well, because again, there's something here about getting a balance, isn't there, for ourselves at any point in time. And I like this visual representation of managing our own levels of stress and burnout, because I guess it's what we ask people with diabetes to do, isn't it? That we expect and want them to optimally manage their blood glucose within a certain level at certain times, time in range, certain levels, certain targets. And in the same way, arguably, we could and should be doing that for ourselves in terms of our stress and distress levels, where we try and keep ourselves at that top of that curve, at that peak performance level, where we're not kind of not bothered and we're falling into being a bit bored and uninterested and too comfortable and not performing, but equally where we're not falling into this, feeling exhausted and irritable and starting to feel signs and symptoms of anxiety. So again, if we can self-monitor our own signs and symptoms of anxiety and distress and know what our flags and what our tells are, it can help us think about how we then map ourselves onto this curve and tell ourselves where we might be at any one point in time. Sometimes people even find it useful to use this as a scale of 0 to 10, where 0 is on the very left-hand side and 10 is on the burnout side, and saying, well, today I'm a solid 5 or 6. That's good. I'm doing all right today. Me doing this presentation today, I think I'm more in the slightly stressed, overpressured side, so I'm probably more at a 7.5 at the moment today. But that's okay, because sometimes we need that bit of stress to motivate us, to keep us focused and doing what we need to do. Okay, we talked in the beginning as well about the idea of burnout not being an all or nothing experience, that it exists on a continuum for all of us. And again, just a slide to help illustrate that, looking at this as a continuum and thinking where we might be on that continuum at any one time in relation to any particular situation, work or home or both. When we're talking about burnout, we're talking about that more struggling impairment end, where people really are struggling in terms of performance at work, where external additional help is required. And hopefully for most of us, if we can undertake good self-care and we can be aware and cognizant of the risk of distress and burnout from our job roles, we can help keep ourselves more to the left-hand side of this scale, towards a healthy and occasionally feeling stressed, but then undertaking behaviours and tasks and exercises, whatever it might be, to help mitigate and reduce that stress. So I'm just going to skip that slide just to talk a little bit about, I'll quickly mention it, sorry, being indecisive. Resilience is something that's been talked about a lot. A few years ago, it was like, it was all about resilience, wasn't it? It was like, oh, make people more resilient and then we won't have people stressed and going off work. As a clinical psychologist, you want to make my toes curl, then talk about making staff more resilient in order to prevent burnout. We've already established burnout, distress at work, it's an occupational hazard. It's dependent on the environment in which we are working. So you can have the most resilient person in the world. If you keep throwing them back into a toxic environment and a challenging environment, sooner or later, they're going to experience signs and symptoms of distress and burnout. The army recognizes this. They have the most elite soldiers. They don't train these soldiers to become more resilient and even more muscly and tough and able to fire even more guns. They recognize that actually the most elite soldiers at some point need backup, need to be withdrawn from enemy territory or hostile territories in order to replenish and restore. And the military actually has replenishment programs. Arguably, this is something that we could implement and should implement in the NHS, but I don't think we're quite there yet. So again, just a nod that yes, resilience is good, and yes, resilience is helpful, and yes, we can all learn to be more resilient. But it doesn't mean to say that you're not resilient if you start to experience distress or burnout. That's really important to recognize. Okay, so thinking about this on a systems level, if folk are in charge of teams or work in teams or manage people, 5 key principles for promoting workplace health and well-being, and I've got the reference for that on this slide so people can follow that link to the full document. But 5 main principles, and these revolve around a systematic review undertaken around this area. And communication is really about supporting the organisation or the team. It might be if the organisation is too challenging for you to initiate or effect any change, and maybe thinking about your team or your group of people. What communications are needed to help maintain well-being and to promote and reinforce resilience and to help people talk about challenges or distress that they may be feeling or experiencing and to seek appropriate help. Regular communication is key. And again, this is one of the things that we see disappearing when demands are really high. You know, it's really, really busy. We've got 1 million patients to see. There are 72 people on the ward. We're short-staffed, so team meetings are cancelled. Supervision's cancelled. Any time out is cancelled. Again, I would argue at those times of high demand, this is when we actually need those pauses and those spaces to be able to regroup and regather even more. Coherence is this idea that there's a consistent narrative on the importance of well-being. So if you're a manager of folk, that's not saying to people, well-being is really important and we really care about you being well and not burning out. Oh, but by the way, tomorrow morning you have to go and work on this ward, or you have to go and do this clinic, even though you have no training and you don't know where you're going and you don't know anyone. That's real lack of coherence, sort of having a narrative around well-being, but then actually undertaking behaviours that are inconsistent with that narrative. So something about looking at how operational practices and procedures might be impacting the narrative around well-being and helping or hindering that. Something about commitment, perseverance, that healthy teams don't just happen overnight. They develop, they grow. It takes a little bit of time. Evidence shows that. There's evidence behind that. And it is possible to kind of overcome some of the things that can get in the way of healthy teams and healthy workplaces. Consistency is also about kind of matching existing ways of doing things with the narrative that you have around health and well-being and staff well-being. So there's something about if people already informally meet and have supportive conversations and get a lot of support and reduction of work-related threat from those conversations, we don't then just badge, oh, we're just going to call those peer supervision. That actually consistency is about adding in extra benefits to things that are already in place, rather than just simply replicating what might already be there and saying, oh, we've ticked the box, that's okay. And then there's something about creativity, and this relates to the social norms I think we touched on when folk were asking the questions and making the comments earlier. You know, what are our social norms in our workplace, in our organisation in general, but also in our diabetes MDT or in our small group of folk that we might be working with in a shared clinic? You know, do we encourage unsafe working hours? Are we modelling staying really, really late and not going home? Are we modelling not having lunch and skipping lunch? These social norms are really important and can be looked at and can be challenged as well and lead to change. I'm aware of time, so I'm going to whiz very quickly. There's just 1 or 2 last slides. So thinking about context matters. three main questions, thinking about where you might be now as a team, as a group. What does improved and embedded well-being look like in your workplace for you at this particular point in time? And then thinking about how you might be able to sustain well-being in your workplace. The Royal College of Psychiatrists has a whole guidance document on optimising wellbeing. And again, I'm not going to read through all of this here, but just to show their summary on 2 slides and the references there to help you in your MDTs or your systems to optimise wellbeing. And I think that's roughly where we finish, with a bit of time for last questions. So something about moral imperative, duty of care, self and others to maintain wellbeing. Strong evidence of impact on quality and outcomes in all the key performance indicators. Recognising the level of demands on ourselves and that there are barriers to seeking help, thinking about self-compassion and the need to apply that actually that's a clinical competency. Recognising vulnerabilities and impact of the work that we do, using screening, asking the questions, not just for people with diabetes, but also for ourselves in terms of our well-being, and then looking at system and individual workplace health and safety, because ultimately burnout is a function of occupational hazards, not a medical diagnostic problem. Okay.
Brilliant. That's fantastic. It's a very good overview of the issues that we face and the challenges and how we might look at them, might be change the way we look at them, and also try and sort of understand them in a different context, maybe in the healthcare context that we ourselves deal with every day, and to say, this is not a failure, to acknowledge that we need to take time out, that we need to seek help. Mm-hmm. It's like the rubber band elastic mm-hmm. that can stretch so far, which is needed for things to happen, but not stretch too far. And also, if you're on a flight, there's a crash, you need to get your own oxygen before you can help someone else. So really important and interesting. Yeah. Couple of quick questions, and there's been a lot of discussion and things in the chat, which has been very helpful. Any tips for people that are experiencing stress-related memory issues and where you feel that they have to write down everything that happens in order to not forget? Is that a sign of stress maybe, and maybe they need to seek help because they're taking on too much?
Yeah, it can be. People, when they think about stress, distress, they automatically think of the physiological responses, but very often it can be those sorts of more cognitive, subtle things, that inability to enjoy your book, so people stop reading, and then these sorts of changes in behaviours creep in. So yes, it can be. Writing things down, those sorts of memory aids, all the stuff that we might talk with patients about can be helpful. But I would say that if that's something that's ongoing, maybe there's something needed in terms of reducing levels of stress to help people get that kind of cognitive clarity back and help recover their memory or concentration or attention.
Yeah. And in terms of, this was very interesting. I mean, I was, thinking of it as the resilience thing as well. And it was interesting what you said about the whole resilience issue, in that, yes, you build resilience, but that's not the answer in this situation, is a very important takeaway for me, I would say. Yeah. And I think it's important also to recognize that there are many different sources of support, and it may be that your immediate manager or my immediate manager may not know the answer, but I think organizations in general, particularly in the last 12 months, 18 months, yes, have recognized this more, and there's more and more resources that are being put out. Yes. And sometimes we do have to take that first step and help ourselves, isn't it?
Yes.
And seek out those resources and not wait until we're having a crisis or a crash.
Yes, absolutely. That proactive action is really important, and it helps keep us on that left-hand side of that continuum, rather than waiting and waiting and waiting until we hit burnout and then needing to sort of come back from that difficult place.
Yeah. I think the woodcutter comes to mind. Sharpen your axe because you're going to be more efficient. Yes, you might think that's time wasting, as in taking time out to feed yourself, look after yourself or colleagues. But these acts matter, because that means that then, the next consultation is going to be better and help the patient as well. Yes. So thank you very much. And I think we're at the end of time. Thank you, Dr. Frizelle, for a fantastic talk.